Welcome back to Girl Talk with Dr. King. Today I have Dr. Shaakira Haywood Stewart, clinical psychologist in New York, private practice, who will be joining me today. Today we're discussing something that I think is very prevalent in the Black community as well as the largest community is fibroids. People come to me all the time discussing fibroids, asking about treatment options. So I'm going to discuss that today with Dr. Stewart. How are you today?
I'm doing well. How are you?
I am amazing. Thank you so much for joining me.
Thank you for having me. It's honestly a privilege to be able to talk about this topic, especially as a psychologist. This hits home for me personally, but also a lot of my clients because they are women of color.
Yeah.
And I'm just really excited to sit here with you and to chat about this topic.
Same. Let's jump in. Tell me, what have you experienced on the clinical psychology side about fibroids and your patients that have that issue?
Yeah, I typically, it's usually presented with some of my older clients, maybe like 30s, early 40s. And they typically, like, we're doing our regular work, talking about therapy, talking about depression, anxiety, stress. And somewhere along the lines, because I also feel it's super important to talk about the holistic body in terms of mental health, mind, body, spirit connection.
Yes.
And so oftentimes when I start with clients, it's when was your last physical? When was the last time you went to the dentist? What does your exercise, your movement look like? All of these things are important in terms of managing your mental health. And so at some point down the line, they go to their gyno,
Yes.
they go to their regular doctor,
Yes.
and they share with me that they are having their fibroids removed or that they have a large amount of fibroids. They're trying to figure out what to do. They're trying to decide if they should take a holistic route, if they should work on their stress management and their diet. And I've had a few clients who've actually had, either a total hysterectomy or, had fibroid removal surgery.
Yeah.
And in the talks of this, we talked a lot about their stress. And then for me, on a body level, in terms of the body and mental health connection, talking about where we keep our stress, especially when we think about the wound area, we think about trauma, we think about maternal stress, all of those things is so important for me.
Yes.
And I often see a lot of trauma with a lot of women, whether it be with sex or, mother attachment sort of things in that wound area. And so important for me to talk about as well.
Oh my goodness. So we need people like you. We need people who are going to be able to treat the mind and the body together, right? So like I treat patients, I treat women of all colors and all creeds and all ethnicities, but sometimes Black women feel like they do not have a safe space to just talk about those things. So I salute you in the work that you're doing. Do you understand the idea of fibroids, like what fibroids are?
No.
Okay.
I mean, I kind of, but I want you to know. I want to know from you.
Sure. So fibroids are benign. And when I use that word, a lot of times I have to use words that patients understand. So I say, I know you understand what benign is, but non-cancerous. So fibroids do not cause cancer, but they are tumors. And when you say the word tumors, that causes fear and anxiety in women. The tumors that grow, they grow from the muscular layer of the uterus, but they can get so big, they grow on the outside of the uterus, inside of the uterus in the muscular layer, and they could actually start to expand into other organs, right? They can put pressure on the bladder, they can put pressure on the bowel. I've had patients who one time her uterus got so big it was pressing on her ureter, which is the tube that connects the kidney to the bladder. And she was going into renal failure because she was not being able to collect the urine. So she had to get surgery right away. So I bring that up to say that it's very prevalent. And sometimes you have the ones with the big uterus, but sometimes they're tiny and people don't even know they have them. And we say we don't bother it unless it bothers you. So there is a multitude of treatment options that we have, but really I listen to the patient and they tell me what they're dealing with. What are some of your patients' symptoms? What do they say that they...
Yeah, I would say mostly just pain in the abdomen area. That's usually what it is. Some bladder issues, some bladder concerns, but that's usually it.
So for the most common is abnormal bleeding or really pelvic pain. Those are the most common. You can have other things. You can have bladder issues, bowel issues. That is more rare, but especially with abnormal bleeding. And so patients are like, well, I didn't know it was abnormal. It's been my normal, right? And so if they don't come and talk to me about that, I would not have known. Some patients are like, well, I have bleeding in between my periods. I have periods that last 7 to 10 days.
Wow.
And when I have a period, it's like I'm having a baby every time, right? And so fibroids, I like to tell patients, have a mind of their own. They bleed when they want to bleed. They collect, we call it the vascular. So the vessels for the uterus feeds the fibroids as well. And really we see it mostly in reproductive age women. The estrogen is what kind of stimulates them. Do we really know where they come from? We don't.
Oh, wow.
We think that it is a genetic predisposition, right? So a lot of times people say, oh, my mom had him, or she had a hysterectomy early, or, you know, it runs in my family. And this is to be separate from endometriosis and other things that can cause abnormal bleeding or pelvic pain. And so when you come in and you give me those things, then I'm trying to evaluate you for each thing. I'm not going to put you in a box and say, oh, this is what it is. I mean, we do a full evaluation, do a history and physical first. Sometimes I can feel them. Sometimes they're so big, they're like up to here, you know, or sometimes we'll do a pelvic sonogram. And how we evaluate them are different too, because it depends on your age. Depends on if you want to have babies or not. You know, like it's a lot that goes into it. And I've seen a lot of frustrated patients say that the doctor told me I had to have a hysterectomy. My mom, I bring up my mom a lot because she is just pivotal in my life, but my mom had a hysterectomy really early, probably in her early 30s. And she said they told me I had to have a hysterectomy, and they took out uterus, ovaries, everything in her early 30s. And so I wanted this conversation today because I wanted to let patients know that they have options. Hysterectomy shouldn't, not saying that you shouldn't have one.
But a last resort.
Last resort.
I've had a client come in who had a very similar situation, emergency hysterectomy, and didn't even get the option to say, maybe I wanted kids, you know, young, early 30s, and that was completely taken away from her. And that was the work that we were doing, was the trauma, that loss, that grief around a future potentially.
And so I think that sometimes when women go to the doctor, sometimes we are dismissed, we are unheard, and we don't get those options. And then now they're in your office because we didn't do the things that we were supposed to do correctly. And so that's the purpose of these talks, is I want my audience to be able to say, hey, I may have heard this online or on the radio or at a podcast, that maybe I do have other options. And there are. You know, we start off really, really gentle. Like you can just take maybe sometimes birth control, the IUD Mirena. I like that one because if people are suffering from abnormal bleeding, sometimes you don't even get a period with the IUD. Right? And so let's start off slow. So we'll start off with medical options, and sometimes patients can't take estrogen, and so we tailor it to the patient. So I do not want patients saying, oh, that doctor online said I should get the pill. I'm not saying that. We have to tailor it to your medical history, but that's one option. Another option is getting something called a myomectomy. We remove individual fibroids. Now, technically, that's only for women who are still childbearing, and we kind of want to save your uterus for that because it is a very risky surgery. Sometimes you can end up having a hysterectomy anyway. So those are just kind of for those people who are like, look, I'm trying to get pregnant. I'm getting pregnant within the next 6 months to a year. Can we do this so I can have a baby? And then I can deal with my fibroids. That's fine. You know? We have something called, and these, again, what I care about is that I am meeting the needs of my patient. So if you're still trying to have babies, there's certain things that I can't do for you. So a uterine artery embolization, that's when we cut off the blood supply to the uterus, right?
You need that blood supply for that baby.
You need, you know it. You need it for the baby. So that will be when we're done with babies. Something called they call it an ablation. So a endometrial ablation, where we burn the lining in the inside. We need that lining for the baby.
Yeah, definitely gonna need that lining.
That won't be your option either. Sometimes we can go in and remove fibroids if we can go in and see them.
Yeah.
Like if we're doing like a DNC.
Yes, that's what I was
Right.
gonna say.
Yeah, right.
I know a little bit.
You know a little bit. Sometimes we can remove it, and we call that a myosure. So we hysteroscopically. So you still have your uterus, and you're not doing anything invasive. I mean, it's still surgery. So there's other things that we can do before we get to that hysterectomy. And I wanted you to know that that's something you can counsel your patients, is that, hey, find a doctor who can give you options.
Yeah.
You know what I mean?
And someone that's going to hear you. You know, I think that's so important.
Yeah. I really think that's important, especially in this day and age where they can choose to go anywhere.
Yeah.
We just need someone who's going to fight for us and be there for us. And fibroids, again, are a big deal. It's very prevalent in our community.
Absolutely.
And I think that people tend to suffer in silence.
Absolutely. I think people often think that an abnormal period is normal.
Right. I tell my patients, you shouldn't have to suffer every month for this period. Like, it's not that deep. Like, we need to help you.
And to think about how those hormones actually impact your mental health.
Yeah.
You know?
Can you tell me a little bit about that?
Yeah, I think as well, when I'm seeing some of these clients that come into my office, they are experiencing, you know, mood shifts, you know.
Sure.
They're dealing with PMDD, you know, and they're dealing with a lot of different issues in regard to their hormones. And so it's so important to also make sure that that is in check, because you might be having mood swings, you might be having, you know, depression, you might be having a lot of anxiety, but that could be regulated with, you know, regular hormones going through your body.
Yeah. Can you explain to our audience what PMDD is?
Yes. So PMDD is premenstrual dysphoric disorder. And I'd love to, you know, hear you share a little bit more about that.
They changed it. So we used to just call it PMS, but you know, we get fancy with things. So PMDD has changed from PMS to PMDD, and it's a sense of depression. Every time you have your period or right before your period comes, it can start to kind of like press you, and you're like, oh yeah, I'm about to get my period. Or you get sad, or your mood changes, or you eat a lot, or you know, you're looking for caffeine. Different people have different triggers. And so that can be related hormonally, not necessarily related to fibroids, but definitely related to your periods, which is another talk we're going to have about abnormal uterine bleeding. That one of the symptoms, of course, or one of the reasons could be fibroids, but that's not always the case. But I just wanted you to know that you are doing the work. You are helping our patients. And I think we need to have more of a team of meeting of the mind and the body. And you know, we can't make duplicates of you. I wish we could bring you to Maryland.
I mean, I can go there.
You can go there. But I think we just need to make sure that patients are equipped with what they need to carry on this journey.
Absolutely.
So I thank you for being here today. I thank Dr. Haywood Stewart for being here, for us discussing fibroids. Again, we talked about what are fibroids, where do they come from, and what are some of my treatment options. So I look forward to speaking to you all again, and thank you for joining me for Girl Talk with Dr. King. Yeah, so back in the day, we used to call it PMS, and then it goes to PMDD, which is fine. We notice that patients come in, or actually, they see things prior to their period. They'll feel things, their mood changes, depression, migraines, want to eat more or not as much. All of these things are happening right before the period start, and that does not necessarily relate to the fibroids, but definitely abnormal periods. So we will have a discussion on that again. Thank you.
Okay.
Okay.